Hello, everyone. This is Kate Barlow. I am your host and founder of the International Mentorship Program. Today we have Dr. Patricia Meyers, and she is going to talk to us about upper extremity rehab. Thank you so much, Patty, for coming.
Hi.
Thank you.
All right. Well, thanks for having me. I have to be a little patient with my technology here with this, but my background is in physical disabilities, working primarily in an outpatient capacity. So working with patients with problems that affect their whole upper extremities and essentially their whole body. And most of my patients have been with patients that have been injured at work. So that allowed for acute injuries as well as chronic injuries and anything from neurological to orthopedic injuries. So I think a wide berth, amputations, upper extremity and lower extremity. So a wide variety of injuries that can happen, and again, treated in an outpatient setting. So if there's any questions about that, I'd be happy to answer that. And I think that, you know, when we think of upper extremity rehabilitation from our perspective as occupational therapists, then we look at the person from a holistic view, right? So while you know, they come in because they may have had an injury to their shoulder, maybe tore a muscle in their rotator cuff muscle, for example, but they're more than that injury, aren't they? We need to really look at them from their whole being, like what's important to them, what do they need, what is it that they have to do, and what is it they want to do, and how can we get them back to a level of function that they feel that's valuable to them and that they feel they can be productive and useful. And so again, while in this venue, we are certainly looking at their physical concerns, but while thinking of that, we have to consider their emotional as well as psychological and their social, because all of that, of course, helps with the their rehab process. You know, I think the most important thing to consider is that collaboration with our parents, with our patients. That's what becomes so important. And I think that what is so important is the fact that we, as occupational therapists, really aren't necessarily the experts, right? We understand injury and we understand recovery and the process that's needed. But if we don't understand what's important to our patient, what they value, what is it that's most important to them, then the whole process, the whole rehab process then really, in my view, won't be successful. So really taking that time when your patients come in, just to really get to know them. What is it that, you know, how do they view their injury? What do they see as being the limitations, or how have they been able to compensate or adapt because of their injury, right? And then from there, we just take their lead and go forth. Like I said, most of my work has been with people that, you know, had an injury at their job. And so understanding the kind of work they do, they're the experts. And I think that shows an immense amount of respect when the first minutes with our patients is spent just listening to their personal story, and then, you know, interjecting our skill set as we as occupational therapists do. So again, I think that collaboration becomes so very important. And again, what makes us, you know, different, I think, in the world of phys dis is the lens, you know, how we see our patients, and we look at them really with a broad stroke. They are more than their injury, and you know, they have an identity, they have a value, they have connections that they identify with that makes them who they are, that individual piece. And so while two patients may have the same injury and have hurt themselves in the same way, we all understand that how we treat them might be different, because again, what's purposeful and meaningful to you might not be so much to me. And so really taking that time with them in the beginning, I believe, is what makes us as occupational therapists successful with upper extremity rehab. So I just wanted to kind of, this is a two-part lecture, and I certainly welcome any feedback you have at the end or after to Dr. Barlow, because I want to be sure that I'm giving you what you all feel will be helpful. But so I did throw some definitions in just so kind of we're all on the same page, right? So when we think of the idea of range of motion, that's really the movement that happens at the joint, right? And in my world, that primarily is the shoulder, the elbow, the wrist, and certainly all the digits. That's not to say that I don't consider the movement in the hip and in the knee and the ankle. I do, but in terms of direct treatment, as occupational therapists here, we spend more time with regard to the upper extremity. We do look at the lower extremity with regard to function in terms of how someone is able to maneuver, for example, in their home or in their workplace or with the activities they do. So we do look at lower extremity movement with a functional lens. When we think of strength, we think of that as being muscular force then, or the force produced by a muscle during the maximum contraction of the muscle. And then coordination is that accurate controlled movement that happens, and that's kind of a combination then of range of motion and strength. And then endurance is the idea of being able to do an activity, whether it's purposeful or or whether it's purposeful or whether someone has to do it or needs to do it or wants to do it. It's being able to do something over a period of time. So to go into these a little bit more then, so range of motion then, like I said, is that amount of movement that occurs at a joint. But we want to remember again as OTs that the piece that's really so important is then that there are influences to movement. We all can sit here now and we all can, bend our elbows or, raise our arm overhead, move our shoulders. But we understand that limitation then might be more than what's happening from a physical perspective. And then we have to think of the client factors, psychological factors, environmental factors, of course, skeletal factors, and then just our own measurements, how we as occupational therapists are measuring it, because there are those factors that have that influence then. So again, I think what makes us so successful working with this population then is the idea that we look at the person from a holistic view, and we understand that movement is more than what is happening at the joint then, and we get that these other factors can have a direct impact, both negative and positive, and we as OTs need to be able to address that. So I guess like an example could be, right, if someone comes into my clinic and they have injured their shoulder, and so they have trouble raising their shoulder overhead, to get something that might be on a shelf, right? And so that could be due to the fact that they don't have the strength to raise their arm. That could be due to the fact that it has limited motion at the shoulder joint, the glenohumeral joint, and that could be a reason. It could be the fact that they are frustrated or maybe depressed by the fact that they can't move their shoulder, and so they don't even try to move their shoulder. And so those are three different examples of reasons how moving the shoulder might be influenced. And so we as OTs then really have to cull that information out and try to help them and to figure it out, because it's all different. Are we working on improving range? Are we working on strength? Or we're just helping them just get through the fact that because they're so used to taking care of their family, or they're so used to, providing for their family, now because of their injury to their shoulder, they can't do it. So they're really depressed. Well, then we have to address that as well. So again, by looking at the person from that holistic lens, we then define and decide the best treatment. To call further into this, and this is just, I am a little detail driven sometimes, but I think it is important. I know at least here, for us here in the US, it's really important to be sure that what we document is clear, and because our patient care is so driven by insurances and the cost of insurance, and that it will be paid for. And so I think it's just good practice then to document what we do. So we want to be able to understand that when we think of range of motion, that's just a general term. we can't assume just by using the term range of motion that active is assumed. And so when here in the classroom now, or when I'm documenting, when I work with my patients, I'm really clear to be able to say, well, what's happening? Is it active, or is it passive, or is it active assistive? And as you can see from the slide, those terms are out and are written out. And I think that it's just important then, because it really, everyone's on the same page. So if I'm an OT working with a patient and then some other OT is seeing the patient next time, there's no questions about what's being done. And again, from our perspective, it's very clear to those paying for the services what's happening. And then for those in the medical field, our doctors or our the healthcare professionals directing the care, they also know what's happening. So again, I think being specific is important. So passive means that it's being moved by an outside force. And so that just means that, we as the OT are actually moving, for example, that shoulder into the direction that we want to. Active range is the patient's muscles. They are actually moving the joint through an arc of motion without any assistance from us or any device. Active assistive then is sort of between the two of them, and that means that the patient starts moving of his or her own accord, and then that motion is then completed with an outside force, and an outside force includes any sort of mechanical device, as well as us as the OT working directly with them. Functional range of motion then is just the motion needed then to perform those activities that are essential to their everyday life. And so when we define functional range of motion, the part to be clear about then is that will be different for everybody, right? So if I can raise my shoulder, raise my arm to shoulder height, right? I'm 5'6". If I'm standing next to somebody that is 6'4" and she raises her shoulder to shoulder height, it's going to be a lot higher than mine just because she's taller. And so again, so functional range isn't necessarily a degree of motion then. It's again the ability for people to perform essential activities of daily living. And so when we think of that, we think then that it isn't necessary then maybe for them to have full range of motion. So if your patient comes into you and they, for example, can reach up to wash their hair or maybe put jewelry on, those sorts of things, but they aren't able to fully get their reach overhead. Well, if they don't need to do that, but they can do what they need to do and they're happy with that, then that may not be what our goal in treatment has to be then. So again, when we think of functional range of motion, it just means the amount of movement at the joint, which is necessary to perform essential activities of daily living. And that again will vary depending on the person. So part of this then is I'm going to talk about assessment. So when we think about range of motion, this is just a bit of a review, just so again, I wanted us to kind of all be in the same place, but the goniometer is a pretty standard way to measure range of motion of the joint. And so just so we're clear, I just labeled the parts again, but we think of one of the arms as being the stationary arm. That's the part that's going to be aligned with the non-movable part of the joint. And then the fulcrum, that circle, that centerpiece then goes over the joint, right? And again, we line it up with a bony prominence because we understand that that's consistent, right? We don't want to be lining up with a scar or a freckle or a skin blemish or a tattoo, because those can change. So again, the fulcrum is lined right up at that joint where the movement's going to take place, and then the movable arm then is aligned with the bone, but it's the distal part that's going to be moving. And so at the end of movement, then we actually have a degree of movement, and then that's what we use for documentation. When we think about what does it mean to get these measurements, and that's all great.
Sorry, Patty. Can everyone try to mute themselves? We're getting some feedback, and I'm not sure who it is. Sorry, Patty. I'm trying to
No, it's okay.
find the mute. Hello, everyone. I'm having difficulty finding out where all the feedback is from. If everyone could just mute themselves, I would greatly appreciate it.
All right. Oh, all right, I'm going to start back up again. Hi. Can you hear me okay?
Yeah, sorry, I found it. That was my bad.
Okay. Hi, everybody. I'm back. So to my colleagues from Africa, I just noticed while I was watching in my background, you can see I had the privilege to visit Nairobi. My sister lived in Nairobi for a couple of years, and so I had the opportunity. You can see the Cape Buffalo over my shoulder here, you know, from my time in Nairobi in the area there. So anyway, and I did actually, by going to some of those places, I did touch into Uganda a little bit, and so anyway, so back to this. So I talked about the idea of the goniometer, again, being the way that we use to measure range of motion. And again, range of motion, we never want to say that, I believe we should never say the term range of motion when describing with our patients, because we can't assume active, right, until we put the A in front of that. So for now, I'm going to talk about interpreting active range of motion. You can see the A is in front of the ROM. And so,
Patty, I'm going to interrupt real quick. Victor,
Yep.
did you want to ask a question? Your hand is up.
oh,
You'll have to unmute yourself if you wanted to ask a question.
oh, I don't see anybody. I see Emmanuel.
Okay, never mind. Go ahead. Sorry.
Okay, no worries. And so we understand that when we, again, I think that's where we're so great as OTs, right? We have to remember then that available range is more than the movement that occurs, right? But there is variation, and what contributes to limited range, right, is age, the work that people do and the activities people do, gender, the actual joint, and the level of activity. And so it stands to reason, right, that it's someone that's 20 years old, when they raise their arm overhead, it's going to be a bit easier than somebody that's 90 years old. It's not to say the 90-year-old won't do it and do it as well, but there's going to be joint changes that just happen based on time, just based on time and use. And so we want to consider those factors then when looking and making some interpretation about the information we get with our goniometric measures. We spent a few minutes discussing the idea of functional active range of motion, and that was determined to be the motion that is sufficient for people to perform the activities or occupations that they value, right? And I said this, but just to reinforce that full range of motion is not necessarily needed for all valued tasks and occupations. Many moons ago when I started out practicing, that would be my goal. I was like, oh, I've got to make sure that person gets full range of motion. And then as I recognize that isn't always necessary. People just are innately creative, you know, and people need to do what they have to do, right? And so they figure it out. And I think you guys can attest to that for sure, that, you know, the ingenuity and the creativity, I am over impressed by how people do what they need to do with what they have, right? And so in the same way with, you know, physical possessions, it's the same with our bodies. People figure out what they have to do with the motion that they have. And so again, functional is considered if somebody is able to do what they need to do, and they're able to get through what they have to do in a successful way. So there is a difference between full and functional active range of motion. When we're assessing our patients then, we look at passive range of motion. You can see how I'm using those terms now. So the P is in front of the range of motion. And passive means that you, the occupator, this is where your skill set comes in what you feel, what you're feeling happen. And so when you take your patients, in this case, their shoulder or their elbow or their wrist, for example, and you move it, you can make some decisions about what you feel, like where does the movement end? We call that end feel. And, you know, and that helps us decide what we're going to do. But in a very general way, again, and this is again, you know, some just general guidelines, but if your patient has decreased passive range of motion, typically then you can feel comfortable thinking something's going on with the joint. All right. If passive range of motion equals active range of motion, and both are not full range, you want to look at the passive first, okay? So if the person's passive range of motion, that's the movement you do with your patient. You move that body part through its movement. And then you watch your patient do it, right? Their own muscle control, that's active. If those two movements are relatively equal, but not full, meaning that they have partial range, you as the OT then want to address passive first. So in a general way, we start with passive and then we progress to active assistive, which we remember being that the patient moves by their own muscle control, and then we as the OT assist. And as they get better, our assistant backs off a bit. We're either going to join in later in their range, or we're going to provide less assistance. That denotes progress then with active assistive range of motion. And then of course from there it's active range of motion by patient's own muscle control and accord. And then the last step to that, of course, would be the strengthening. And strengthening denotes us in some fashion providing resistance. So when do you do passive range then? The purpose of it is to get, you know, to improve overall tissue length. And tissue encompasses a lot, but we think of it, and within that is muscle. You know, just think about that. If someone's in pain, or, you know, they fell and maybe fractured a bone, or they overused their arm to lift or to carry some object, for example, muscles get shortened. And if they're protecting, for example, they're protecting their arm, they may flex their elbow and kind of keep it tight to their body, for example. Well, then the muscle itself is going to be shortened. And if the muscle's shortened, it's going to be much more difficult, for example, for them to extend their elbow if they've held it in flexion, you know, to protect it. And so starting right away to have them lift and move stuff, yeah, you're not going to be as successful. In this case, you really want to lengthen that tissue. And so that's where our stretching comes in. So passive range allows us as the OT to do that movement for them. Instead of them using their muscles at this point, you essentially are being that external muscle force, if you will, to help them, you know, lengthen tissue. You know, adhesions happen, you know, from disuse, from immobilization, for example, and contractures. And so the purpose of the passive range and when we do it is when we want to make sure that that the muscles, you know, have good movement, that they contract and expand. We don't want our patient to be stuck in a certain position at the joint, like with the elbow bent, for example, or the wrist bent, or the hand in a fist. We want to be able to, we understand as OTs that for people that be able to do what they need to do and want to do, they've got to have some active movement, right? So we as OTs can work on passive range so that joints don't get stiff or get stuck, right? And we perform, another reason to perform passive range of motion then is that when our patient then is not able to move that joint through their range of motion. So if they're unable to reach their arm overhead, or they're unable to fully bend their elbow or bend their wrist, that would be a good reason for us as the OT to help them or do it for them in this case, that's passive range of motion. And there's of course reasons why not to do passive range, and that would be if, for example, the joint is very swollen. If someone has fallen on the joint, and there's inflammation there, especially if it's early and it's early stages of an injury, we're not going to rush to move it because we want it to heal. If it's early fracture, we're going to be cautious. Again, that all depends on where the fracture is, and there's more specific guidelines depending on what's going on, right? If our patient has a lot of pain and they come into you and they're just like really in agony and they're saying to you, I'm afraid to move it, I have a lot of pain, think about that. You as the OT are not going to be able to passively move them, because remember what passive is. Passive is you, the OT, doing the movement. And if your patient's fighting you, it's like an arm wrestle, right? Then you won't be successful with passive range, because if they don't let you move because they're afraid, they think it's going to hurt, or they're anticipating pain, or they're already in pain, passive doesn't typically work then, because they can't relax enough to let you be the one to move that. And depending on the muscle tear, as to whether you would passively move them. So those are really general guidelines, but again, it'd be a different type of lecture if we got into real specific diagnoses as when to do passive range. But in general, if there's lots of swelling, if the fracture just happened, if they're in excessive pain, or they have fear of pain, if they've had some sort of muscle or ligament tear, or last but not least, if there's some sort of compromised circulation, meaning nothing to do with what you're seeing them for, but they have real circulation issues. And how do you know that? Well, you can tell by color of skin, right? If there's like a mottled color, or like a grayish or bluish tinge, when you compare it to the non-effective side, it might be more red, it could be swollen, it could be more shiny. Excuse me, there could be hair loss, for example. So some of those compromised circulation, if that happens, it's going to be much more difficult to passively range that person. Okay, so circulation may have nothing to do with the injury, but again, it can very much influence passive range of motion. And this is my attempt at a graphic chart for you. I don't know if you find it useful, but essentially across the top, I wrote down active range. I wrote down active range of motion, and that's in that sort of light brown color. And if you look below that, if active range of motion is within normal limits, then you can start to do the resistance. That's the easiest path, right? There's 1, 2, 3 in a row there on the left side of the chart. If now, in that left corner again, if active range of motion is limited, you as the OT have to figure out why, right? And that because if you don't know why, it's going to be really difficult to make some decisions about what you're going to do. And so now it's time to be a bit of a detective, right? Use your OT clinical skills to be able to figure out what's going on. So then we go to passive range. You want to feel, again, passive range of motion is you as the occupational therapist. This gives you the time to actually feel what's happening. Why is it that it's tight? Is it getting stuck? Why is it stuck, and what's happening? You can kind of figure all that out just from feeling. So if they have normal passive range of motion, that's the green in the center of this chart, right? That means it feels normal at the end. Then they just might have weakness. And if they have weakness, then you start thinking about, well, if they can't move their arm against gravity, we start talking about positioning our patients different to be able to move their arm. Because we get gravity as resistance, right? And so if we can eliminate or reduce gravity, because we really can't totally eliminate it, but we understand by positioning our patients in different ways, we can limit the force of gravity, and that can help our patients move better, right? So back to the chart. Purple says passive range. It goes to the green in the center. If their passive range is normal, then we start to think, okay, there's got to be some weakness going on, right? If they have full range of motion, we can add some resistance, right? And if, just as an aside, if our patient can move their arm against and take some a little bit of resistance, we understand that that muscle grade then has to be at least a 2+/5 or a poor plus grade. If our patient does not have full range of motion, then we understand then that the grade is going to be less than that if they can't move their arm against gravity. And then if we go back up to the chart where it says passive range in purple again, the other side says it's abnormal. That means that we may or may not be able to figure out their muscle strength when performing our assessment. So it may not be appropriate, for example, or we may be able to give them a muscle grade within their available range. So what does that mean? Well, back to our patient with the shoulder injury, say that, this patient, comes to you because they fell, they've tripped and fallen, and maybe they've sustained a contusion up to their shoulder. And so now it hurts for them to reach forward. But even before this happened, they did not have full range of motion. They could not reach overhead, So then your goal as the OT then is not to have them reach overhead because they couldn't do it before this happened, right? So then we understand that the goal would be to get them back to the range they had prior to the injury. And then within that range, we can also look at their muscle strength. Another thing, so that's range of motion. Then we start thinking about the idea of strength and grip. Testing grip is an example of testing for strength, right? And so before I even test them with a dynamometer, before I look at how much muscle strength they have, and in the US we do it in pounds, and the devices don't measure in pounds and in kilograms, and I apologize, I should have put both measurements down there. But when we look at grip, for example, look at your patient. Again, the most information I glean about my patient's injury, certainly any information that I've read from the doctor helps. And like I said in the beginning, the conversation I have with the patient is invaluable. But I also watch them. I watch them come in. Do they grip to take a coat off? Are they holding a bag with that hand? Do they turn a doorknob with that hand? And so I'm just watching them. And then I'm asking them that because I start to think, well, if you can do some of those activities, right? Literature tells us it's about 20 pounds. It's considered functional grip, meaning if you have about a grip strength of around 20 pounds, that's basically saying that many of the things you need to do in everyday life, you can do with that amount of grip. So when we look at grip strength, right, grip considers posture, how the shoulders, the elbows, the forearm, and the wrist are positioned, right? Grip strength is measured isometrically, and isometrically means without movement, right? So when they're squeezing the device doesn't move. And I believe the purpose on that is that it's not giving patient feedback. They can't judge how much they want to grip because whether they give full effort or whether they don't, or they're afraid to grip, the device doesn't move. So it does record their gripping then, but it done in an isometric way, meaning it's strength without any movement. So that's something to consider. Again, we observe our patient with strength. Any activity that a patient does that involves grip is not isometric for the most part, but dynamic, right? To turn a doorknob, to pick up a bag, to lift an object, to carry an object, to pick up a child, to pick up a dish, whatever it is that we're doing, that has a dynamic grip involved, right? And you could argue we could also get into manipulation as well, like what fine motor, and that leads us to coordination, where you have to be intentional and precise with the kind of movements. But again, watching our patients, and if we can watch them in their real environment, that's when things are most successful. So if you're watching a person in their home or working outside, or working gardens, and what they're doing, if you watch them, or with their children, or if you watch how they move, you can make some assessment then about their grip strength. How grip strength is tested then: you have your patient seated. Their shoulders are adducted, meaning, close to their body. Their elbows are flexed to 90 degrees, so like at a right angle. Their forearm is in neutral, so the thumb is facing toward the ceiling. And the dynamometer has different handle positions. And so at this point, you're going to put it right in the middle handle, and you're just going to ask them to squeeze. Grip testing does not test sincerity of effort. So we are only testing, we're asking them to squeeze it as hard as they can, but it's what they deem to be full effort. And then the advantage of this kind of testing is that there's data, normative data that we can look at. And I was thinking of adding some of this normative data onto my next PowerPoint, just put it at the end so you'd have it. But you can really start to look at, and normative data looks at a person's gender, their hand dominance, and their age. And you get a range then, and you can really tell then if a person's strength is below or above norms, and it helps you figure out when determining goals for therapy. Goal for max effort grip. I could just talk to you about the normative data, and what the normative data breaks it down by age and by gender and hand dominance, like I said. You ask your patient to grip 3 different times, and it's really the average of those 3 trials, and then you compare that to the normative data. And you can interpret then, is your patient within normal limits? Are they in the high norm? Because again, the normative data gives us a range with the standard deviation. So we get a range now. So does your patient have a normal grip? So the range is, say, 50 to 100 pounds. If your patient grips 75, well, they're within normal limits. If the range is 50 to 100 pounds and they grip 95 pounds, they're really in the high norms. And all I'm saying then is that you can reassure your patient then that maybe they have pain and maybe they're a little afraid to use their hand, but you can say, wow, your grip is high norms. You've really got really good grip strength. And that gives them the reinforcement then to be more comfortable using their hand. And it also gives you as an OT the opportunity to recognize that you don't have to work on grip with them. You can work on something else because their grip strength is good. Oh, I don't know why that's there. Sorry about that slide. There's types of pinches. Pinches and is another way to, is also looking at strength. We talked about grip, that's using the whole hand. And pinch then really focuses on the thumb with use to the index and to the middle. And there's really 3 types of pinches I'm sure you're aware of, and there's different names. I made sure to give you 2 names, just to hopefully they're terms that you're comfortable with or familiar with. But the tip pinch then, also known as the 2-point pinch, involves the thumb and the index finger. And so this is what happens. That's the tip pinch, where the thumb and the index finger come together. So the tip of the thumb to the tip of the index finger. This is considered fine motor, as you guys would gather. It's that precision pinch. And think of something like holding a pin, for example. Palmar pinch or 3-point pinch or 3-jaw truck pinch. that's looking at the tip then of the thumb and touching the index and the middle finger. And that's where it gets the name three-jaw chuck, because it involves 3 of your digits, right? So it's the tip of the thumb to the tip of the index and middle finger. And that would be like holding a coin, for example. And then there's a lateral pinch, also known as a key pinch, and that's where the palmar surface of the thumb, and it's the lateral part of the index finger, if I can do this coordination, there we are. It's this pinch here. And this is the least precise of our 3 pinches, and that would be an example of maybe holding a card or holding a key. That's where it gets the name key pinch. So there's 3 types of pinches. And like grip, it has normative data. You do typically doing 3 trials. And the normative data, just like with grip, looks at this, the data is broken down by age, gender, and hand dominance, right? And again, you can take the average of the 3 trials. I just put this in here and I tried to add a bunch of information into it, so I hope you can see it. But this might be a way to break it down, and I tried to add all the things that we talked about so far today. But the idea that knowing the right or left side is important, for clear documentation. Recognizing, are you measuring active range of motion or passive range? And remember, we discussed active is the patient's own accord and passive is you doing that for them. Manual muscle test is that actual testing that muscle strength, MMT, and we understand that to be on a grading system of 0 to 5. Recognizing if your patient can fully move their joint through gravity, that's at least a 3, okay, and that would be considered fair strength. And so you can just fill out the chart there. I also added motion measurements there. Please be sure to document numbers, both sides, because we can never assume 0, right? And so when, for example, documenting shoulder flexion, then it would be 0 to 180 degrees. And again, you need to label the 180, because what does that mean? A number in of itself doesn't mean anything, right? Labeling in degrees so that everyone understands what you're talking about. And so I put the key movements for the shoulder, the elbow, the forearm, and the wrist. And then I broke down the digits by their MP, by the MP, so you guys know this, like by the MP joint and by the PIP joint. And then the little joint, the most distal joint is the DIP joint. And then I added range of motion just to help guide you there. Remember that when thinking of your digits, and if you're documenting them as digits by number, the thumb is considered the first digit, the index is the second, and all the way through, and then your little finger or small finger is considered digit 5. So either, depending on how you document or see it written. When you look at the thumb, when we start looking at, I wrote down the terms radial abduction or thumb extension. And I did that so that you might see it written either way. I personally like when measuring the thumb, when we measure a thumb extension and abduction, or radial and palmar abduction, they are measured from the CMC joint, and I like the terms radial abduction and palmar abduction, because then I can at least have a guide, because if it's radial, it's on the radial side of the hand, that would be considered radial abduction or extension. And then palmar, going toward the palmar surface, palmar abduction or pure abduction as well, either way. But that's, for me, because I like ways to remember things. So I like the terms radial and palmar abduction versus extension and abduction. Anyway, and then I provided the measurement numbers for the MP and the IP of the thumb. And again, these are these 2 joints here, this being the IP and this one here being the MP of the thumb. And then I did asterisk that because, again, depending on what source you're looking at, the end range numbers might vary slightly, by 5 or 10 degrees, sometimes depending on the movement. So I wanted you to be clear on that as well. And then as we talked about grip and pinch. here's an example of a chart here too, that you really want to know what dominance your patient is. And sometimes they're both, meaning that they may do large movements with their left, but eat and right with their right hand, for example. So our patient may be ambidextrous, excuse me. But knowing what side it is important. So you want to be sure that you always circle right or left. When testing grip, we talked about the dynamometer. You really want to talk about what handle position. Again, usually it's right in the middle. There's 5 handles. So usually handle 3 is what's happening. And then I just put in there 3 trials so you remembered. And then you could just write in the box there the 3 numbers. We're measuring grip. It can be measured in pounds or in kilograms. And then again, the 3 pinches, again, 3 trials. As occupational therapists, you know, what guides us through upper extremity rehabilitation then is the biomechanical frame of reference, right? And so I think it's important to give that, you know, a couple slides here, due diligence, because we want to understand why the biomechanical frame of reference works here. So you would choose to use this frame of reference then with your patient that has decreased strength, decreased endurance, decreased coordination or range of motion, right? And that's all the stuff we've been talking about today. Biomechanical frames and reference would be used to promote or enhance the musculoskeletal system. Again, that's what we're talking about today, that considers strength, endurance, and movement, right? And so this frame of reference basically is saying that due to some change in structure, movement or strength is limited or decreased due to something that happened, whether it be a disease, whether it be trauma, whether it be overused, and whatever it is, it adversely affects our patient's ability to perform the activities that they need and want to do. This frame of reference really is built upon the principles of kinesiology and kinematics, right? And we really are looking at movement. We're analyzing how our patient moves. And like I said earlier, it's more than just what's happening at the joint, right? We want to be, as OTs, I think we have that holistic lens. So we're looking at the whole person then, right? And so I think that, I think this model really lends itself easily to upper extremity rehab. One of the disadvantages to the core beliefs of occupational therapy then is the idea that this model is reductionistic, meaning that it assumes that our patients have muscle control and motivation, and that isn't always the case, right? And within biomechanical frames of reference, this also includes assistive technology. And assistive technology is the wheelchairs and any sort of adaptive equipment that we make or so that our patients are able to walk or able to, coordinate or maneuver, whatever they need to do to be able to be functional in daily routine tasks. So when we think of this model, function means the capacity of movement. And what does that mean? The ability to move enough, have enough strength, and have enough endurance to do what's important to them. That's how function is defined, right? It really looks at the efficiency of the motion that the patient has. And dysfunction within this model looks at the inability of the person to demonstrate the same. They do not have adequate range of motion. They do not have adequate strength or endurance. And the model says that there's something biomechanically happening that's affecting this. And because of their decreased in movement, they have impairments and it interferes with their occupational performance. So what do we do as OTs then when somebody comes in with decreased range of motion and decreased strength, right? Well, we start to think about how, well, if they have some movement, and then you're working with them as the OT and helping them, right? That's active assistive, right? Think about what they could do when they're not with you. You could have them specifically reach, right? They could guide their arm on a hard surface like a table or the floor, right? By having them feed themselves, that's active assistive. And maybe they start to move their arm toward their mouth, and then maybe you can help assist or have a family member help assist with that. Grooming tasks, the idea of, maybe putting a shirt on, maybe shaving, maybe combing hair, putting jewelry on, whatever it might be. An active range of motion, if we're thinking of what to do with our patients, we start thinking about, well, let's combine functional movements to carry food, to wash laundry, to play a game, to do job tasks. We start to think about what movement do we want them to do and what do they have to do, and you can usually combine the two. If you know, for example, that you want to work on somebody bending their elbow, well, then you could, and you want to strengthen the bicep, that, for elbow flexion, well, then you could have them carry their groceries with their right arm if if they're working right elbow flexion. Or you could have them lift, right? Or if you want to work on elbow flexion extension, maybe there's a tool that they're going to use that they could maybe use in their garden, for example, to cut down weeds. And the idea of bending their elbow, extending their elbow while using that. Then your goal is that they're doing strengthening, that they're bending, they're extending their elbow. They're also at the same time, if they're holding a tool, working on grip because they're sustainably holding something. And so you can really work on, you think functional, you can work on more than one thing at a time. To address strength then, that's really the purpose then of therapeutic exercise, right? You want your patient to understand what a normal movement pattern is, right? And so, for example, I want to pick something up and write, and so if I just pretend I'm picking up something, I might be able to do it. But then if I go to bend, to pick something up and it's got a little bit of weight to it, I have trouble standing back up. Well, what's the difference? Well, maybe it's because I have some weakness in my legs. And so I need to address that with my patient to build their strength and endurance in order to be able to carry or to be able to lift something, for example. So really it's about watching our patients move and do what they need to do, right? Therapeutic exercise aids our patients overcoming range of motion deficits. And so if you want to work with your patient, if they have to reach overhead, so have them, they could move a glass, and they can move a plate, they can move a bag of food, whatever they need to do, and you could have them, and then you could have them work to get to a higher level, for example. But strength and endurance can be done in a very functional way. The key is not to just say to your patient, oh, when you get home, lift this bag of food. You be very specific. I really want you to lift it overhead, and I want you to do it 10 times with your right arm. And so once they have real clear guidelines, you can grade it by increasing or decreasing.
I'm sorry to. I would like to ask in a case before you get to the home. What's the role of physical adjunct modalities? Because I'm asking this because usually there's always a clash between the physiotherapist and occupational therapist. So is it that I would like to be very clear on it? Is it that you leave that for the physiotherapist, or when the client comes to the occupational therapy department, you still work using physical adjunct modalities before enabling activities and also before purposeful activities? So I'd like to ask that question, please.
That's actually a great question, and that's the beauty that Dr. Barlow's been gracious enough to let me have another talk. And I'll make sure then I include modalities in the next month. I'm coming back. And I thought about it this time, but I just, I wasn't exactly sure what was needed. But yes, I do use modalities. That's a great question. But here we go. Our Practice Act as occupational therapists across the world says we absolutely, I believe, use what we can to help our patient get better, right? Modalities fall in the preparatory phase of our practice, so they're not functionally driven. So there are occupational therapists that will say to you, sort of to your point, that, oh, leave that to the physiotherapist, it's not OT because it's not function. Well, I 100% do not think that. I use modalities. I have used e-stim and ultrasound and hot packs and cold packs and iontophoresis and phonophoresis and all of them, and flutotherapy and paraffin. So because I know that if they help my patient get better, right, I'm preparing them for function. So I am a passionate believer in modalities, and I thank you for your question, because I will make sure that with the next lecture, when I talk about intervention, and again, you can talk to Dr. Barlow. I'm more than willing to talk about diagnoses or whatever, but we'll talk about when to use them. So yes, as OTs, don't be afraid to use them. But respect them. You need to know how to use them, and that's beyond the scope of a 1-hour lecture. But I can talk about that. What modalities specifically would you use? Hot and cold?
Yes, contrast. Yes.
How about ultrasound?
No. Even though I have a certificated physical adjust modality.
Oh, that's awesome.
Yes. But I usually basically just to relax the muscles.
Yeah.
So maybe yes. So I use contrast baths. But I'm talking because on behalf of some of my colleagues that work strictly in let's say orthopedic hospitals, physical
Right.
settings. So they have lots of physical therapists there. So there's always this clash. So that's what I'm asking. So most times I see my patients on a private practice because I work in a mental health institute. So most times I'm working and I'm seeing my patients on the physical. So I do that and they don't have issues. But I'm just asking that question on behalf of some of my colleagues who are in the physical setting.
Right. I think you're onto something, and I think it's the same here too. I think some OTs just believe in their heart, their OT heart, that there's no place for modalities. And I like you, I think like you do, that there is a place for them. And I think if our patients, whatever we have in our toolbox for our patients to get better, we want to do that. So I applaud you for getting the certification, and I think it's great that you use them. But I think to your point, I think I will make sure the next month I will talk about hot and cold. I think so. I can contrast baths, you said. Do you do much with like a paraffin? Do you do anything with like a warm wax or anything like that, or no?
No. I don't use it, even though I've seen it being used before, and it's been long I've used it, so I just abstain from it. Yeah.
Okay, so I will definitely give some information on that for sure. But when, just to kind of conclude with this, but the thing we want to think about, interventions to address strength and endurance, we don't need fancy equipment to do that. But the key for it to be successful is that there has to be intent. You have to know how to grade, and you've got to know what you're trying to do. So you're not just pulling a number out of your bum, right? You have to figure out what it is somebody's able to do, and then you be able to grade it. So for example, if some of the things when a patient is weak, I may start having them do activities in a gravity eliminated or a position. And then as they get stronger, I do the same activity against gravity. So what does that mean? Well, I may have them on the table, sliding an object side to side. And then I may have them reaching on a shelf to work on strengthening, right? And then if I have them holding, for example, a tool, like we talked about the idea of maybe chopping down weeds or something, you can actually add some weight. I have used towels, and I've used like nails and scrap metal that they've had, and I've actually taped it inside the handle to give it some weight, some pieces of steel, that kind of thing, and nuts and bolts, that sort of thing. And I just tape a towel around it, and then that gives it some weight. And then I do the same motion, bend the elbow, extend the elbow, and that's grading it. To build endurance, I may have them do it for time. I want you to do this for 2 minutes and not stop. I want you to do 10 reps times 3 sets. So again, the idea of my goal is to build endurance, I want them to do this activity over time. If my goal is to build strength, I have to grade it, increasing the weight in some fashion. Whether I can put a weight on a patient's arm or whether I build the weight up on what they're holding. It depends. You can actually use, of course, there's weights that have, distinctive numbers on them, but you can make your own and do that as well. I've used bottles of water. I've used a plastic bottle that I fill half with water and put a line on the bottle. And then I say, okay, you do that. And you can easily do that motion 10 times for 3 sets of 10. Okay. Then maybe if it's endurance, I'll say I want to increase it 10 reps times 4 sets. If it's too easy, now I'm going to fill the bottle all the way to the top. Then I back off on the reps a little bit. Then I put sand in the bottle, fill the bottle halfway with sand, then fill the bottle all the way with sand and just put the cover back on. Do you see? So there's ways that you can grade it just so you're distinct about how you do it and are very clear with your patients, giving them that kind of direction. I think that you'll be very successful that way. And so how to grade for endurance? Well, you grade light to moderate to heavy. You start out doing something over time light, and it can be the same way. So sometimes you can add resistance if sometimes there's exercise bikes and that sort of thing. So we start with light resistance and then we crank the resistance up and then we add more resistance. If I'm having my patients walk, I walk on a flat surface. That's easy. It's nice and smooth. And then I may have them walk on a sandy surface. That's much harder. Maybe I'll have them walk up an incline. That's much harder. So you see, you can grade with what you have around you. And so when you think endurance, you start light and work your way up. And then you also think of time. Start with less time and then increase the time for endurance. So I think that might be my thing today. Yeah, so that pretty much is today's lecture. Like I say, I'm back next month, and I'm definitely, thanks to Emmanuel, I'm going to add some stuff about modalities and specifically hot and cold, and the idea of contrast baths. And I got some great home ways you can do contrast. And I will look forward to your feedback. But that for contrast baths to help with swelling, and it can be easily done by your patients at home, and so we can talk about that. So my thinking would be, if you have any questions, of course I'm here.
Okay, I would like to ask one more. In a case where you have a patient or a client who has degenerative muscular condition,
okay,
where they tire out as the activities goes on. So there's a principle of grading kind of activity where I think you start with the maximum which the patient can do. And
right, I think you might be talking about the idea of like a peer, maybe progressive resistive exercise, right? You have them do their max weight once, and then you back off 50%. And I can talk about that next time too. But then that gives you a line of what to do. But I'll talk about. I'm making notes here, but I'll also talk about the idea of degenerative diseases, because there's something very distinct we think about, because we recognize when people have degenerative muscular, neuromuscular, and neurological diseases, right? Typically they just get worse. So it isn't this today was talking more about the idea of being injured and getting better. You're bringing in another factor, and with that crowd, then our goal as OTs then is being sure that we want them to keep the function they have. And so yes, it involves strength, and yes, it involves endurance, but not at the expense of debilitating them, right? Because that depends on the disease. So I can give some guides to that as well, but that's a really good point. I think what you're talking about though is the progressive resistive exercise. And I used to do that in the clinic. I would have the patient, what is the most they can lift for a one-time rep once, right? And then I use that. So say it's, I don't know, 50 pounds. I then back it down 50%. And have them do more reps at the lower rate. And then there's a formula, but I increase for men, again, I would increase their weight about 5 pounds a week, and with women, it's about half that, 2.5 pounds. So there was, you know, and then I used the guidelines. If they can easily perform, you know, 10 reps times 3 sets, meaning they got good body mechanics, you know, they don't look like they're going to blow a blood vessel in their face, right? Holding their breath, and they look safe and they don't have pain. That gives me a guide to be able to increase, you know, increase the weight. But yes, you're right. That's good. That's a good way to, yeah, that's a good guideline. Yeah.
Does anyone else have any questions? I have pretty much muted everyone, so you will have to unmute yourself if you'd like to ask a question. All right, while you're thinking of your questions, if you want to email me, I can add the questions to Dr. Meyers, and she can add those to her next presentation. So my email is Kate, K-A-T-E, period, Barlow, B-A-R-L-O-W, at AIC.edu. It's also on the chat box if some of you want to look at the chat box. And Dr. Meyers, this was our most well-attended session yet.
Oh, that's awesome.
18 people in and out. So please forgive my trying to mute everyone as they come in, but this has been the most attended session yet. So I'm so thankful for your topic area and expertise. And
so,
yeah.
I just want to be sure that for me, the most important thing is that I can meet your needs, right? So as you know, that I mean, this upper extremity rehab is such a broad topic. I could be the speaker every month for the next year, and have something to talk about. So to let you know, I will bring in the idea of the use of hot and cold next time. Talk about neurological and degenerative disease processes. I want to talk a bit about, and maybe I don't need to, I was going to talk a little bit about the idea of sensation and the effects of sensation with nerve injuries and how that should be assessed. That's part of that upper extremity rehab. And then I'll talk about the idea of determining what weight someone should start at, that I can put some information about that too. But I have a question for you. I don't know anyone can answer, but I know, Manuel, you've been talking. Do you guys assess grip? Do you formally assess someone's grip strength beyond having them squeeze your hand? Do you actually use a device to measure?
For us, we use the dynamometer. Yes. So
and you have the normative data.
The pinch. Yes.
Good. It's great. It's great to give I love objective data. I love the fact that we can use objective data and then apply it to function. And then it helps us write our goals and plus it makes our patient feel good, right? You know, if they think they're weak, because people associate pain with weakness. It doesn't, sometimes I have to say to the patient, oh my gosh, you're very, very strong. It hurts. And I'm like, yes, it hurts, but pain and strength are not the same, you know? And so when they see that number, they feel better about themselves, you know? And then that's part of it. If they start to feel more confident, they're more likely to participate, do you know, right? I got just this funny story. I had this patient one time, this young guy, about 20 years old, right? Big muscles. And he had a strain. And he was my patient, and the patient in front of him was a man that was almost 80 years old, right? And so I was testing the grip of the 80-year-old man, and his grip strength like blew the norms out of the water. He was gripping out, like, if I remember right, like 140 pounds, and he was like 80. I'm not even kidding. And I was just like, oh my God. So of course I talk fast, and I'm all excited. I'm like, wow, I can't believe how strong you are. Well, then the 20-year-old big muscle guy comes in next, and he starts to squeeze. And I'm like, okay. And I'm writing down his numbers. He goes, am I as strong as that other guy? And I was like, he goes, you were all excited about his numbers. And I'm like, no. And he was all sad, you know? And I said, what's the older gentleman? I said, how do you have such great hand strength? All his life, he had milked cows. And even though he grew up on a farm, and even though he lived more closer to the city now, he always kept one cow. And every day, he was milking that cow. I said, well, whatever you're doing, your hand strength is very, very strong. So anyway, so it is the activities that you do that you have value that help with hand strength for sure. So anyway, so yeah, and please let Dr. Barlow know. And I, again, want to be helpful. So anything I can do, just let me know.
Well, thank you so much, Dr. Meyers. And we had a lot of newcomers that are not part of our our mentor list group. So
Okay.
if you would like for me to send you all the email notifications,
Sure.
the recording links, please email me your just your first, last name, what country you're from, and your email, and I will send you all the notifications for our meetings. They're twice a month, and the times, and I will send the recordings because I record all the sessions and then I send them out. So email me if anyone would like to join. And thank you so much. Are there any other questions before we wrap up for today? All right. Thank you, Dr. Myers. This was
All
great.
right, thanks. Happy New Year to everybody. Thank you.